27th meeting of the Joint Conference Committee and ask you to call the roll.
Sure. I'll start with you, Commissioner Chow.
Present.
And Commissioner Green.
Present.
I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. Would you like me to call the items, Dr. Chow?
Yes, please.
Sure. Item 2 is the approval of the August 23rd, 2022 ZSFG JCC meeting minutes.
So we need a motion for that, please.
Move to approve.
And I would second. Is there public comment?
There's somebody on the line. I'm not quite sure if that person's staff yet. I'll have to check on this, but person on the line, if you'd like to make comment on the minutes, which is item 2, please press *3 now. All right, no public comment, commissioners, and I'll take your first and second as an action because there's only.
Well, unless there are people who are in attendance here that might also want to add a correction. We'll give everybody about 5 seconds here. Okay. And if not, then I agree with you that we'll have accepted it. I do think it's good to ask our attendees also.
Sure. But so it seems like that's not happening. So we can, so the minutes are approved and we can move on to the regulatory affairs report.
Okay, thank you. Who's going to give that? Oh, Adrian.
Hi, good afternoon, Commissioners. I'm sorry. I was having issues unmuting myself, but I managed in the end. Good afternoon. Thank you for giving us time on the agenda to present our regulatory affairs update for September 2022. As you can see from our report, we have a number of pending surveys. We've added a number of surveys on the pending surveys that are approaching towards the end of the year. So those additional ones, we've added the CDPH General Acute Care Hospital Relicensing Survey. It'll be 3 years since our last survey in February of next year, so we can anticipate that anytime. We also know that we are expecting our Joint Commission Hospital Accreditation and Nursing Care Centre surveys in early 2023. That's only 2 years since we were last surveyed, but the Joint Commission did tell us that they would be coming closer to when they would have been coming if our last survey hadn't been a year late, if that's a long way around of explaining what I mean. They're trying to get back on their regular schedule. And then we also expect our Joint Commission stroke certification survey. The window opens for that in December, but we anticipate it after the first of the year. Of note regarding our certification, the Joint Commission are retiring the TBI certification, so we will no longer be eligible to participate in that program because it's not being offered to any facility. So that will be one less survey for us to participate in, but that team are keen to continue to find ways to demonstrate the great work that they do. No new completed surveys to report out on in this report. We did submit 2 plans of correction. One was for a hospital-acquired pressure injury, and one was for the Joint Commission laboratory survey. At the time of writing this report, the submission was pending approval, but we received notification today that our plan had been approved and that we were fully accredited for another 2 years, which is great news for the laboratory. Based upon feedback from you regarding how to display this data, we have a 3-year look back that we will change after the first of the year to a 2-year look back where you can see the number of outstanding cases. We're also looking to see if we can actually begin to look at this data in a different way around actual numbers of reported and not just open cases, because both of those things are important. You can see that our biggest volume of cases has consistently been privacy breaches. We have seen an increase in reportable HAPIs in the last 12 months. That's multifactorial, and if we look at the data calendar year versus fiscal year, the numbers look very different. We're also working with OC, our wound care specialist, to do a deeper dive on some of those cases to see if we can understand if that's statistically significant, that increase. When we move further down the report, we can see that we have 3 new reportable events, 1 retained foreign object, 1 privacy breach, and 1 additional HAPI. They were all reported to the state, and of note, the retained gauze post-procedure, the state have chosen to not investigate that report and have asked that we work collaboratively with the Joint Commission to investigate and submit our root cause analysis, which is underway right now with the Joint Commission so that they can assess the rigorousness of our report and our corrective actions. ALCC occurs on the 29th of this month, so we don't have any outstanding monitoring data to present to you this month, and did just want to share with you that the regarding that specific HAPI that we reported, that we mentioned at the top, the specific findings for that case was there was a failure to document that we disclosed to the patient and a failure to document that we notified the physician around this case. We did some direct corrective action with coaching, and we prepared some education for nursing and physicians using our regular do no share format that's been well received by staff. Welcome any clarification or questions or comments that the commissioners have on the report today.
Again, Mark, would you check for public comment?
There's no one on the line, Commissioner, at the moment.
Okay, good. Commissioner Green?
Yeah, well, I'm delighted to hear about the information today. And I really love the way this is being presented, and think, your suggestion about having the open cases as a function of the total number would be really helpful to understand, just to see which of these various open events are being cleared faster, whether they're in fact prioritizing one subset over the other, and how the open ones relate to the totality of the different categories of fries. When you talked about the happy corrective action plan, and then you mentioned that that the numbers were up. Are you incorporating what you started with that particular case as part of your further analysis and management of the happy? And I assume you guys are always on top of everything, so I figured you were.
Yes, we are. So both the cases that we've talked about, the one that we submitted the plan of correction for and the new one that we reported, will be included in our overall analysis. We actually, as we were speaking, one of the HAPIs, the providers have stepped in and done some deeper analysis on the patient, and we feel that may actually be a vascular injury and not a pressure injury. So we're going to reach out to CDPH regarding that last reported event to clarify with them that this was a vascular and not a pressure related event. So that would take the numbers down from 8 to 7. And sometimes the investigation takes longer than the 5 days in which we have to make the determination to report, and that's often one of those. It's one of those catch-22 situations where you want to be timely in your reporting, but you find out additional information that may have negated or changed the report that you make after that deadline has passed. So we'll work with the state on that. But yes, all of these events will be included in our analysis.
Great. Well, thank you. That's the only question I had.
Thank you. I thought that this was a helpful way of presenting the summary of the categories of the events and therefore the privacy breaches really show up as continuing and increasing over the last 3 years. Uh, do we have a reason that that might be happening, or is this just um, the randomness of our system, or is it because of Epic, or what?
So I think there are three things going on when we look at this data. The first thing that I think when I look at this data is these are open cases. So the fact that there are more open cases in 2022 makes sense to me because they've only just been reported and may not have been investigated yet. The second thing that I want to also, think through as we look at this data is this doesn't reflect the overall number of privacy breaches that have been reported. So that data may be a lot more meaningful than open cases for us. Because from this data, I can't identify whether the amounts have gone up. I can only identify the ones that are open. And thirdly, I think it's important to also recognize that privacy breaches have a longer timeline to report them within, and they're investigated by a different branch of CDPH. So they're on a totally different timeline with some nuance to the regulations about what, how, and when we report them. So those pieces are not reflected on this graph, and may also affect the turnaround time of those investigations. Privacy breaches go directly to Sacramento, and a centralized office in Sacramento investigate them as opposed to the district office.
Yeah, I don't want to interrupt, but there seems to be some sort of emergency I have concerning a fire. I'm not sure if it's our house in Santa Clara. So perhaps, Dr. Green, you can just do some information while I have to take care of this call. Okay.
Sure.
Well,
Absolutely.
please take care, Commissioner.
Yes, Dr. Chow, take care. And just for the record, y'all, when we lose quorum, what we can do is continue an informational meeting. No votes can be taken, no actions can be taken, but the meeting can continue. So it's okay to move forward. And let's just think of thoughts for Dr. Chow.
All right. So there doesn't need to be any kind of approval on that. And we have the next thing is the Hoshin update, right?
Correct. Thank you. Thank you, Adrian.
Well, I hope all goes well with Dr. Chow, and I'd just like to take a couple of minutes to introduce this item. I'm incredibly excited that we're here to talk about Hoshin. It's one of the most important things I think we would ever talk to you about as an organization, because this represents our strategic roadmap. And one of the things I'm really proud of in this organization is that even as we went through all 6 phases of our pandemic, we have been able to continue our strategic work. So that's very exciting. I want to really thank the KPO team who you'll hear from today, and that includes Dr. Jim Marks and Chris Ross and Jenna Belinsky, who has recently moved from the KPO onto our executive team in a new exciting role. But they've really been able to support us as we've moved forward in this, and you'll see that as we go along. One thing I want to say about this presentation is that it's going to feel different to you. We have, just like we do everything else, we are continually evolving and improving the way we do our strategic planning, which is incredible. And even though it appears to be a different paradigm, I think as I've reflected about what this really is, it's really a more accurate presentation of the way our strategic work has worked over time. You'll see it as a flow as opposed to a static point in time. And in truth, even though we've presented Hoshin as a static thing that we do once a year or once every 12 to 18 months, it really does represent a flow, because by their nature, these strategic initiatives are in different places at different times. So keep that in mind as you hear the presentation. And as always, we really welcome your thoughts and reflections and suggestions for improvement. And I guess one other thing I'll say is that This potion, you'll hear from the KPO, you'll hear from the different executive sponsors of the 4 strategic initiatives we have this year. Even though that work is assigned to leaders in particular, as an executive
It's
team.
okay, thank you.
Oh, thank goodness. Glad to have you back. Even though it is assigned to specific leaders, we really take very seriously our responsibility as an executive team for all of the strategic initiatives and all the strategic work. And I couldn't be prouder of our team. We have the most magnificent team I've ever worked with. And so I'm really excited for them to share with you our strategic direction going forward. That's it for me. Take it away, Jim and Chris.
Thank you, Susan, for the introduction. And as Susan described, myself, Will Hune, and Chris Russell covered the first part of the presentation with kind of where we are in our thinking about strategic planning and deployment. And then you'll hear from the executive owners of our 4 current strategic initiatives. So next slide, Chris. So just wanted to start by defining a few terms so that we're all on the same page. It's been a while since we've talked about strategic planning and deployment. So HOSHN, which you saw as a title on the first slide, or HOSHN Conry, is our method of strategic planning in which strategic goals are established, communicated, and put to action. It's important to keep in mind that, a lean strategic plan is management by resource, not objectives. In other words, we prioritize the most important work and undertake only that work that we have the resources, largely the people, to support. And so strategic planning and deployment is as much about what we choose not to do as opposed to what we choose to do. And it's really this level of focus that allows us to achieve true north. A couple of new terms that you probably haven't heard applied to strategic planning and deployment. The first one would be flow. So we certainly know about patient flow as patients flow from the ED to inpatient to home. Here we're talking about flow as a continuous process for strategic planning and deployment. So previously, we've pretty much batched strategic planning and development, where we annually develop a plan, implement it, and then the next 12 to 18 months, revise that plan, bring in new strategies, sometimes continue old strategies. By flowing strategy, new strategic opportunities can be identified and developed throughout the year, and successful initiatives retired. This allows us to be more nimble and pivot to higher priority initiatives strategically, as opposed to firefighting. An incubator is actually a tool and a process we use to visualize strategies as they move from initial steps of being under consideration through A3 development, and then for that strategy to be deployed, and then ultimately to be retired, with clear gating criteria for moving forward from one step to the next. One implication, as you heard from Susan, about flowing strategies, is that you're going to see our strategic initiatives in different stages of development, ranging from under consideration to deployed. Key performance indicators, or KPIs, are the metrics we use to measure the success of the individual strategies. These are typically 12 to 18-month goals. So for example, CLABSI County and Falls for our safety initiative. Our True North outcomes are 3 to 5 year metrics that help us understand whether we're achieving True North. So for example, in the safety pillar, our star rating, and ideally our strategy and key performance indicators for that strategy drive our True North outcomes. And then finally, catchball, which we typically apply that term to our development of our A3s, is structured sharing and conversation to support understanding, feedback, and alignment of the work. Next slide, Chris. So you're familiar with our True North pyramid, with our patient and communities at the top, our vision, our mission, our values, and our True North goals in the 6 pillars. And our strategies are really the beginning of the process by which we achieve our True North goals. Next slide. So digging into a little more detail, again, with the pyramid visualization, we have our True North pyramid at the top with our True North goals. To achieve True North, we are flowing strategic planning where we develop our strategic initiatives, the measures of their success, the KPIs. Something new this year, a project plan where we call out the specific work and milestones along a timeline in order to ensure that we are tracking on deploying that strategy. This gives us leading indicators that are likely to occur before we actually move our key performance indicators. So basically, the project plan says, well, this is what we're going to do, and if we do this, then we should hit our KPIs. If we hit our KPIs, we should drive True North. Each strategic initiative has a strategic team which engages in shared problem solving with individuals that include our operational leaders, our directors, and then our management. And all of that work is ultimately typically deployed down to very close to or to the front line, supported by our daily management system. And so what this allows us to do is align our entire organization around achieving a relatively small number of True North outcomes and key performance indicators driven by a small number of strategies, but to do the improvement horizontally across the entire organization. And then next slide, Chris. I'm going to end my part by just showing you that when we develop our specific strategies for ZSFG, we need to take into consideration that we are part of the health network and that has a strategic plan, and that the health network is part of the Department of Public Health, which has its strategic plan also. So we want to be sure that the work that we're doing and prioritizing aligns with the most important work of the department and the network. So I'm just showing you here at the department level, there are currently 3 strategies: hiring and developing a diverse workforce, improving health outcomes for people experiencing homelessness, and the DPH way to improve with data to enable and align. At the network, there are also 3 initiatives that align with the DPH initiatives. And the arrows attempt to show some of that alignment. So at the network, reducing overdose death and equity, improving access and flow, and then effectively managing our revenues and expenditures. And then you see the 4 strategic initiatives under development or deployed at CSFG: achieving safe and equitable staff experience, achieving safe and equitable patient care, harmonizing and synergizing access and flow across the ZSFG campus, and leader proficiency and linking financial performance to operations. So I'm not going to talk, I don't want to spend a lot of time talking about how all of these link and align, but you can clearly see that a network initiative to improve flow and access throughout the entire network links very tightly to a strategic initiative at ZSFG to harmonize and synergize access and flow across the ZSFG campus. And they actually share some key performance indicators or pieces of key performance indicators. And with that, I'm going to turn it over to Chris. Or I think to Will, actually.
Good afternoon, Commissioners. Thanks for the time. One slide for you here. This is a graphic that's intended to clarify our higher level roadmap for the ZSFG strategic deployment cycle, which is really actually a pretty complex series of processes. And frankly, it's become an organizational habit, I think, at our organization over a period of 18 to 24 months. So this is an attempt for us to distill many of our experiences, our learnings, our innovations over the last 8 years or so that we've been doing strategic deployment in this fashion. So what you heard from Jim really describes where we start at number 1 here, reflecting on our True North and our mission. We are often thinking about how well we are doing on our mission and our metrics from the previous year, as well as trying to align with the DPH and network priorities. That's 1. What you're going to hear next from Chris is actually 2, 3, and 4. So I'm staying at the high level here. Where the incubator process helps us to establish goals and targets, develop and catch ball those strategies throughout the organization, and then operation and implement through the development and implementation of the project plans themselves. Moving forward, and we can always come back to this and share with you as we're getting to 5, 6, and 7, but to see how this connects with the ZSFG way, well, as we start to implement, you want to support the departments and units to continuously improve through Plan, Do, Study, Act, standing up visual management and data systems to monitor how well the strategies are going, and then supporting follow-up at all levels of the organization, removing barriers, tier reporting, standardizing what we can, continuously improving where we need to. That's the high level, and Chris is going to take you through the teams are, you'll see the different strategies between 2, 3, and 4 here through the incubator. But ultimately, the point we want to make is that the purpose of the deployment cycle is really about alignment, empowerment, and continuous improvement of our leaders at multiple levels, whether at the DPH network levels, all the way to our units and our departments, and helping make sure we accomplish True North and our mission in alignment as we can.
Hello, Commissioners. I'm Chris Ross, the Strategic Planning Manager in our Kaizen Promotion Office here at ZSFG. I'm going to walk through a quick summary of our strategy incubator. This is a tool, as we mentioned a little earlier, that we formalized this strategic planning cycle to help us visually manage the development of our strategic A3s. So our incubator here has 4 lanes. Again, this supports our flowing of our strategies. Any strategy at its infancy will start over on the left side. We work through the left side of our A3, and as this is catchballed with our exec team and our expanded exec team, that input is incorporated, and we can flow to the right side here, where we start thinking about what are the actions we're going to take, what are our countermeasures, and then ultimately, what are the resources that we're going to need. So the incubator helps us see visually where our different strategic A3s are, which A3s are still learning more about their current conditions, which A3s are working on freeing up their resources, for example. So once a team goes through their left side, their right side, we start working on a project plan that's going to call out specifically, here's how we're going to do these actions and who's going to do them. That leads to conversations around capacity and the resources that will be required. And then ultimately, when we align those resources and we're able to move forward, our strategies will move to the final stage here of resources deployed, where our owners, our executive owners, will support the deployment of their project plan and follow up this progress through our key performance indicators. So our strategic A3s will flow from the left side to the right side as they are developed. There might be occasions where they incubate in a stage. Again, maybe we're waiting for some more data. Maybe we're waiting to free up some capacity. So the key players around these countermeasures are available to really drive this work forward. So now we'll show where our current strategies sit, and then we'll give our executive owners an opportunity to dive a little deeper into their strategy. So we'll start from the right side here. We have our finance strategy around leader proficiency and linking financial performance to operations. The strategy is very similar to our strategic A3 from the previous year. So this is an instance of one staying within that resources deployed as that work continues to operationalize at the department level. Then we have our harmonizing and synergizing access and flow across the ZSFG campus. Again, very similar strategy to what we had the previous year. So this work will sit within our resources deployed lane in our incubator, again, as these teams are working on implementing their various countermeasures. Then we have our achieving safe and equitable patient care. This team is right in the middle, working on the right side while concurrently drafting their project plan. So determining what we're going to do and then laying out some of those concrete steps to accomplish that. And then our achieving safe and equitable staff experience is moving from finalizing their left side, including their KPIs and their analysis, to taking that work and determining what countermeasures they would like to put in place. So now I will throw it to Jennifer to kick us off with the finance. And I think if it's all right, commissioners, we'll run through all 4. Each owner will get about 2-ish minutes just to give an update on their problem statement, their KPIs, and then I think we will take questions at the end.
Yeah, that's fine. Thank you.
Okay. All right,
Good
Jennifer.
afternoon, Commissioners. Jennifer Boffey, Chief Financial Officer, here along with my co-lead, Jenna Belinsky, our Chief Integrative Officer. We are leading the Finance A3 this year, which is a continuation from last year, as Chris mentioned, leading leader proficiency in linking financial performance to operations. Our A3 is fully deployed. Our problem statement this year, it's a unique year for us. We need to meet our budget while stabilizing and optimizing core operations, normalize our COVID operations, and maximize our revenues. We chose this goal specifically because there is a lot of work to do this year, in addition to stabilizing in a new normal post-pandemic. Our KPI for this year is to meet our budgeted payroll target. I will hand it off to the next group. Luke.
Thank you, Jennifer. Good evening, commissioners. Jillian Otway and myself are the individuals who are leading the work on access and flow across the ZSFG campus. You are probably familiar with this as it's been one of our HOSHN strategic aims for the last several years. We've taken a slightly different approach this year in that we are trying to not only harmonize and improve flow on our campus, but really trying to link it back with the San Francisco Health Network and the Department of Public Health, which is one of their key strategic aims as well. So really trying to ensure that we have a unified, systematic approach for how we think about flow and access of our patients at all points of their care continuum in our health network. We are continuing to focus on really three key performance indicators. One is ambulance diversion rate. The second is medical surgical lower level of care patient days. And then third, next available appointment for all of our outpatient adult specialty care clinics. We are also fully deployed for our A3 and have been implementing much of our elements of our project plan over the last several months. And we look forward to sharing with you our data and the progress we've been making in each of these areas over the next several months. And I will hand it off to the Achieving Safe and Equitable Patient Care.
Hi again, Commissioners. For the Achieving Safe and Equitable Patient Care, myself and Lisa Winston, Chief of Staff, are the executive sponsors for this A3. We have a great team supporting us, and we're currently in the developing project plan stage of the incubator. We have developed KPIs, and they're a mixture of process metrics and outcome metrics, and I'll come back to those in a few minutes. And our focus from True North is equity, safety, and care experience, but we're really looking at our CMS star rating as one of our drivers. Our problem statement is, whilst aspiring to be a 3-star hospital and improving in 3 of 4 patient safety drivers since 2020, ZSFG has historically performed at a CMS 1-star level, and the ongoing disruption of the pandemic and staff and patient safety vacancies places patients at risk for negative impact on their safety, experience, and equity. Our KPIs, the outcome metrics of our KPIs, we're going to continue to monitor our harm dashboard metrics of CAUTI, CLABSI, colon SSI, and falls with injury. And we are currently working on 2 new metrics that focus on both patient safety, patient outcome, and CMS star ratings. Our process metrics are around PIPS and DMS live departments, actively working on driving or watching metrics that are aligned with patient safety. Our culture of safety response rate and dissemination of the results of that, and the implementation of our new DPH Safe software, which will allow us to better capture safety events, safety ideas, and enable us to have data that revisits the nimbleness that Dr. Mark spoke about. As we understand more about what's happening in the hospital to our patients, we can act more decisively on new trends that we see. I'll hand off to Andrea for the Achieving Safe and Equitable Staff Experience.
Thanks, Adrian. Good afternoon, Commissioners. My name is Andrea Turner, and I'm the Chief Operating Officer here at the General. I am a co-owner, along with my partner, Margaret Damiano, on Achieving Safe and Equitable Staff Experience. This strategic HOSHN covers the True North pillars of equity, safety, developing our people. Our problem statement is, as increasing number of staff do not feel safe at work, we need to improve staff safety in order to avoid burnout, loss of staff, and staff not recommending ZSFG as a place to work. Our KPIs that we do feel will drive us towards our target are number or percentage of number of Form 3s completed within a certain number of business days. We're working with our HR partners to achieve the baseline and to reduce the severity of physical assaults reported by the UL or our new safe system on the horizon. Thank you.
Thank you all for sharing. Commissioners, here are some of our next steps. We will bring back an update very similar to that incubator slide to show the development of our A3s and the implementation status. And as we all went through our KPIs, those will be incorporated on our True North scorecard, which we will bring quarterly starting in January of 2023. That concludes our presentation. There's questions. Go back one slide.
And I just want to thank our outstanding team. You can see it's a big one. We have our 8 executive owners, and then we have our outstanding KPO team, Jim Marks, Will Hewen, and Chris Ross. Very deeply grateful to them for supporting this work. And I'm eager to hear your reflections and questions.
Thank you. Thanks to all the presenters. It was really helpful to hear this in person. Just reading the slides led to not a clarity as to how this was happening. This presentation was really very clear. So thank you very much. Is there any public comment, Mark?
Yes, before I go to public comment, and I'm sorry, I had a family emergency. I had to take a call, and so I'm not sure if you all addressed this, but Chris, can you send me this version, or can someone send me this version of the presentation so I can get it to the commissioners? Okay, great. There is somebody on the line, person on the line, if you'd like to make public comment on this item, which is the item 4, host an update. Please press *3. *3. All right, no hand, commissioners.
Okay, thank you. So Commissioner Green, any thoughts?
Well, this has been an absolutely terrific presentation and so emblematic of the kind of teamwork that we hear about all the time from all of you, and the really intricacy of thinking that's gone into this. I am just overwhelmingly impressed by all of this work, and we'll really look forward to seeing you reach your benchmarks, which, you know, I think, as you said earlier, it's what you include and what you don't include. And I think that the things you've chosen are so important, so topical, so critical to all the issues that concern us the most throughout the network at this point in time. I'm just blown away by the quality of this work. I guess the only one question I had, and, you know, as Dr. Chow said, the slides didn't give us the depth of incredible information you shared with us in the presentation. The wheels are all turning here. But I was curious on your safe and equitable staff experience, whether you had been thinking about what we often hear in the commission, which is this whole issue, and we hear in the vacancy reports, about how to address, you know, staffing stresses, understaffing. What happens if the you know, emergency declaration goes away and we're back to the old forever time it takes to fill positions, and wondered, you know, since that might be something we have to confront going forward, whether that's something that you would incorporate in this whole staff experience. It seems like a pain point we hear about often, and whether some of that is, you know, partly timing with contracts and such, or some of that is obviously what we hear every meeting about some of the struggles of finding adequate staff.
Yeah, I can start with that. In all of this work, we really want to focus on things that are under our direct control. And the truth is that this metric, which I realized as Andrea was speaking it, you might not know what we're talking about, but filing a Form 3 is really the first step in the hiring process. And it is something that managers do as soon as there's the intent is, as soon as there's a vacancy, we file a Form 3 with HR, Human Resources, and they take the process, you know, of course, in conjunction with us from there. So I think, you know, this team has really thought deeply about the metrics here, because there are many that can be considered. But we think that these 2 metrics address different pieces of the staff experience. One is related to hiring and filling jobs, and this is the part of filling the first part of the process of filling jobs that is under our control. And the second has to do with workplace violence, which of course is a huge healthcare industry issue and problem, and reducing severity of events that happen to our staff is something that is really important, obviously, and helps us understand better how well we're doing at preventing not just all episodes of workplace violence, but really the most severe. And this one is better than looking at all events because we know that there's a lot of underreporting. So this one helps us really narrow into the meat of the problem.
Well, thank you so much for that clarification. As I say, this is just fantastic work.
And Dr. Green, just to build on what Susan was saying in terms of working on things that are under the span of control of your division, one of the three strategic initiatives at the department level is on hiring and developing our diverse workforce. And they have a metric, time to hire from Form 3 submission to start workday. So they're working on that piece of it. And we have we actually align to that because we have a piece of work that's, the time to the Form 3 submission.
Great, thank you so much.
Did any of the other members of the that are in attendance today want to add to either elaborate more on perhaps the areas they're working with, or to sort of help explain further? It's hard not being in person because you can start looking around and select some people, but it just seems to me that I think Dr. Yoon said it, that we've been in this process for like 7 or 8 years, and it's really sort of unbelievable that it's been that long. Because I remember when it first started, there was a question what this was all about, and it just seemed that there was really a very complicated process of looking at issues and then solving them. But in these years, and I think this presentation particularly helps to understand that we've now built in flexibility. We've sort of limited our horizon somewhat to what I think Dr. Ehrlich presented one time was over a dozen parameters that we were going to try to achieve, and instead come down to realistic numbers that really sound like they're very important for us as an organization and for our patients. Dr. Marks has taken this, I think, again, to a remarkably operative level, which I know he started with, and we were impressed with his work with the ER flow, but this seems now to have caught on with the entire hospital organization, which is where it began. And looks like you've also then influenced the entire department. And I think those of us who have been following this are now becoming, or at least I am, more comfortable with this as a process rather than just busy work, because everything that's on that A3, you can picture how many hours went into it and whether it creates any real change. I think looking forward to, because you've answered every one of my questions that I was writing down here. When were we going to get the next progress reports, and how are we going to see that we were going to get to number 5, 6, and 7? And since you've answered that, I don't have anything to ask, but just to really look forward to a progress report in January to see how these very clear goals are going to be followed through and are in progress. So I really appreciate that. I appreciate your updating of the slides. The use of the term incubator now again in now another field. And it actually is a very nice word, because I think it helps us picture that, this is not something that is kind of cookie cutter and sitting out there and it's mechanical, but it has the potential of really creating a new way of doing something. So I think whoever named it or how you're using it, at least to us who are looking at this, this seems to allow a great deal of flexibility in being able to move to the goals. So I'm looking forward to that also. Uh, so thank you again, and Dr. Marks, for your leadership, and everybody who is really participating. Every one of the executive sponsors are all very busy. So just to even come in with the goals that you have here and your anticipation for the coming year will allow us to appreciate the scorecards as we're looking at your True North results. So thank you.
We have an amazing team, Dr. Chow.
Well, I think every meeting you're proving that there's another area in which you are all striving to really achieve what the final top of the pyramid is, right? To be the best hospital, and no longer are you saying wherever. Well, that's actually what had bothered me in the past. What are we talking about? The best hospital in San Francisco, California, the United States? But now I can understand even better why you just didn't limit yourself. So. Thank you very much.
Thank you for the kind words.
Mark, are there any other comments you think that we have on this item?
I believe we can move on. Thank you. I'm sorry I missed it. I'll look at it on the tape when I go back and do the minutes.
Yeah, it's really very exciting and really a wonderful presentation. I think as we get into some results, and perhaps it would be after we have 1 or 2 quarters, a presentation to the full commission would really be in order as a demonstration of how well True North works and going back to its core and its roots, its birth, which was here at the General. So let's keep that in mind.
Absolutely. Great idea. Item 5 is the ZSFG Chief Executive Officer's Report and Emergency Department Newsletter.
Well, I'm back with you again. Thank you so much for hearing our report today. As usual, we start with the COVID-19 updates. And as you know, we're at a pivotal time now with the pandemic. As the pandemic wanes, we're doing a lot of changing of our guidelines, which we detail in the report. It also makes time for us to do other things like strategic work, which we're very excited about. Number 2 has to do with our MPOX response, and I just can't resist taking this opportunity to thank our urgent care clinic, which has just, always done an outstanding job, has done an amazing job responding to MPOX. We've had a lot of visitors recently, which you see in our report. We've had California senator, we've had our local supervisors, we've had assembly members. We've just had quite a number of people. You can see their photographs and report on this, and we've been very proud to show them the work that we're doing. It is the 150th anniversary, or it was. So on August 28th, 1872, this remarkable place got its start here on this campus. I was inspired by the reports from Laguna Honda to look and see who was the president of the United States on that date. And it was Ulysses S. Grant, it turns out. So it was indeed a very long time ago. But we will be celebrating throughout this winter and up until the Hearts event, which the foundation sponsors every year. And this year will be a hybrid event. It'll be at City Hall as well as on virtually attended, which is really great. We are celebrating Hispanic Latinx History Month here. Our team, headed by Ayanna Johnson, is just doing an amazing job celebrating in all different ways. And I think I will stop with that, the narrative parts, and see what questions you have before we go on to the data.
Commissioner Green, any comments on this first part of the report before we get to the data, and then we'll ask for public comment after the data.
No, thank you.
Thank you.
Okay.
Well, I was just going to reflect on the 150th anniversary because with all that we're doing here for equity and all the celebrations of our different populations, wanted us to remember how long and how far we have come since at the very beginning. And as part of the times, the hospital was not taking certain populations. And in the case of the Chinese, this is where I knew about it from the Chinese hospital that started. Uh, it would only take the most serious tuberculosis cases. So much has changed in these 150 years, and I hope you can highlight that as you go along with the celebrations that all of our communities are now cared for, and that everyone is equal in the eyes of all of our staff here as patients. So wanted to thank you for that. And if there's something we can all do for it, I'm sure that the commission would be happy to try to work with you on the celebration of the 150th anniversary.
I'm sure we will think of a way, and I really appreciate you bringing up the topic of equity. It is something, as you know, we take incredibly seriously, and we didn't talk about this in the context of our strategic goals, but you will see on the scorecard that we still will have an equity metric. It's the same one that we've been following about departments driving equity. And we are very devoted to ensuring that equity is imbued throughout the other 4 strategies. So I'm eager to show you how we'll be doing that as much as possible when we report to you in January.
Well, very good. Thank you. Why don't we go forward with the data, and then we can answer public comment and
Great.
review the data.
So we start with our well, this shows 5, but the 6 surges. And fortunately, now at the end of this really nice graphic of the surges, you can see that we are definitely waning at this point. I think the part of this chart that gives me some pause is to see those 2 big spikes in the middle of this chart, which represent the last 2 winters. And it makes you wonder what we're looking at this winter, but we really don't know. And hopefully that winter pattern will interrupt with respect to COVID. But whatever happens, we will obviously be ready for it. And the thing that we haven't talked about on this slide that is important to notice is the difference between the first 2 peaks and the last 3, which really represents the pre-vaccination time and the post-vaccination time. And you can see the gray peaks under the yellow represent the patients in the ICU, and you can see the big difference between those two sections of the pandemic. And so whatever comes our way in the winter, hopefully that trend of fewer patients in the ICU will continue as well. Going on to the emergency department and all the data we have there, and thank you, Commissioner Green, for your excellent questions. Please let me know if we didn't answer them sufficiently enough. But one thing you notice right away is that our volume in the ED is going up. And yesterday, in fact, we hit 208 patients in the emergency department, which is really, that's pre-pandemic levels. And you can see that, slow and steady increase with our ED volumes. Now, admissions haven't changed, and that's really, a reflection of our capacity, I think, pretty much. We don't have much more capacity to take patients, which means that the work in the ED is even more busy. The next 2 charts are the ones that I really don't like looking at, but we focus a lot of attention on, which is our leave without being seen and our ambulance diversion rates. And these continue to be quite a bit higher than we would like to see. They're definitely driven by volumes, by boarding, which is a reflection of the lower level of care patients we have in-house, and by staffing that is a persistent challenge for us. We have countermeasures in all those areas, and we will continue to report on our progress in those. But these graphs don't at all represent where we want to be. And we can talk more about your questions about that. Urgent care, of course, helps us quite a bit here. There are many patients every day that are transferred from the emergency department to urgent care. And the decrease that you noted, Commissioner Green, at the average daily transfers from the ED to urgent care, I don't think we actually know exactly why this is happening. Does this represent, basically them hitting their capacity? Does it represent an increase in acuity in the ED, meaning that fewer patients are eligible to be transferred? What we do know is that it doesn't represent blocks. I mean, it used to be before the pandemic that the urgent care would just put a cap on patients coming over, and they really don't do that anymore, which is a result of the amazing improvement work that they have done. And the transfers going the other way are more or less stable. The average daily admissions to inpatient psych is trending down, and that is also based on a problem that we're seeing, and we're also working closely with our colleagues in behavioral health on, which is the issues, the compaction we see with getting patients out of psychiatry. So you can see we have on any given day, 35, 36, 37, 38 lower level of care patients in inpatient psychiatry, which really limits our ability to achieve flow. Moving on to med-surg, this is the graph on my page 14. Again, we can see we're pretty much at a pre-pandemic seasonal levels for med-surg census. Those peaks that you see in the graph are the winter time, and we'll likely see the same peak as we go into the winter season. And it's the same in intensive care. This is a time of year when our census in intensive care is low. Our MCH volume is, trending up, which is great. The only problem we have is, when we have issues staffing, but we have been filling our positions. We bring in registry if we need to, but that increased volume is really great. And then going on to lower level of care, this is obviously trending up. Med-surg, lower level of care. We started, this graph starts in September of 2020. The total of those decertified administrative lines was 23. And in August of 22, we're at 39. So we clearly are having issues with lower level of care. We know some of this is because Laguna Honda has not been open to us for admissions for quite some time, but it's not the only issue, and we continue to work on it. The same acute psych is also higher, but not by much. We've gone from 35 to 38. Still not the direction we want to see, but it's been more stable. I think I think that represents the main trends I wanted to cover. I'm going to stop there and see what questions you have on any of these data, or invite any of my colleagues to weigh in if they would like.
Mark, let's ask for public comment.
There's no one on the line, Commissioner.
Oh, okay. This Commissioner Green.
Well, thank you for all the clarifications. I really appreciate it. So I just want to make sure I understand it right. So if the average daily census in psychiatry is 42 and 38 or lower level of care or administrative decertification, does that mean that the vast majority of our beds really, despite all the effort we've made with our behavioral health and our I think you said it was people who need locked units or special types of psychiatry facilities in order to move out of the institution. So really what we've been doing in terms of our DPA, our behavioral health division, which is more finding beds that don't fit that description. And so what the problem here that you're facing is really a kind of a different niche than what they've been working on in the behavioral health division.
No, I wouldn't actually say that. I think, you know, we're working very closely with our colleagues there, and they're working on, you know, buying and getting beds that are the same types that we need. It's just that they're challenging to get for a variety of different reasons. So, for example, we had 17 patients waiting for LSAT beds today, which is pretty much what it's been. That number has slowly gone up. And I know from working with them and talking with them that this level of care is really challenging to find. It's been hard even now, but you know, through the pandemic especially, because those facilities had the same kind of challenges that we all did with, you know, having outbreaks in the facilities, having staff who get sick, so they can't fill beds that they otherwise would be able to. This is just a really challenging problem overall. But the beds that we need, which are, you know, LSAT beds, residential beds of various types, you know, we're working together, but it's just hard.
There.
And it takes a long time to buy and fill beds, but they are definitely working on it.
Thank you. Thank you very much.
Mhm.
You've actually answered several of my questions, but I wanted to see if we could get a little clarification on the group that leaves the urgent care center, which I'm really glad is filling in the position it is and doing as well as it is in terms of being able to take care of people. But if we send an urgent care patient over to the ED, and I know that you've written an explanation, Dr. Ehrlich, that you know, we of course have to triage again at the ED to look at the you know census right then and what has to be done. But it does seem that this would be a cohort that we should try to figure out what to do with because they were seen by us, thought to need a higher level of care, and then we sort of weren't able to do it.
Yeah, absolutely. And it really comes down to a triage function, even for the patients coming over for urgent care. And it has to do with a bed availability issue. So as long as we have beds open in the back, we can quickly assess those patients and move them to the appropriate pod in the back. If those patients are sent over, you know, in the context of 30 people waiting in the waiting room, then just as described, the staff up front are going to have to look at the severity of illness of all the patients waiting. And, you know, as you say, it's likely that the people coming from urgent care are at a higher acuity, but perhaps not always. It is quite variable. So that's the really specialized function that our staff in the ED are always trying to sort through. Who needs to be seen first, second, and third?
Do you think that we could get, or you could all get a better idea to make sure that the folks who are kind of leaving didn't get sicker and come back, or the type of patient, or is there also some sort of communication back? I was just thinking of this, that urgent care might know that things are really piled up in the ED. Could we do something with this patient and then have them come back half a day later back to us or something like that?
Yeah, there's really good communication and flow between urgent care and the emergency department. I think they've done a great job with that flow relationship. And you know, as mentioned, you know, one of the amazing things that urgent care has been able to do is not block any patients coming from the ED, which helps a lot, especially when the volumes have been getting higher. We're in the process of looking at diagnoses and doing a deeper dive into this group. So we've been working with the ED on that. We're not quite done with it, but we can give you more information about what kinds of what these patients show up with, what are the diagnoses they have, and try to get a better window into into some of the questions that you're raising.
Yeah, it's just that, this is an identified group of people who are ill, and I think it's worthy to dig deeper into it and see if there are ways in which we could, reduce the number of people who then leave without actually receiving any treatment. So,
Yes,
or
absolutely, 100%.
because of that evaluation, they needed something else. So, would appreciate. I think that we'll continue to follow that up. I know that you're all continuing to work on the ambulance issues and all. So, we'll continue to follow. We know you're earnestly trying to get below that. And, we'll hope that in the next several months, things will again settle back down somehow.
Yeah, well, we are working quite diligently on this, and we're engaged in citywide discussions on this topic with EMSA, with the hospital council. It's the issues aren't just here, but they are definitely present here, and we want to work as collaboratively as we can with them as well as internally to try to address the problem.
Thank you. I just wanted to comment that the emergency department report was August 19th, so I don't know if they had any further update. I mean, it was very interesting how to use Epic, but it seemed really complicated. I admire Dr. Green for being able to get through her courses in order to use it. And I just looked at that and thought, well, by the time I finished reading it, I wasn't sure that I could enter anything. But
It's not always the easiest, but we will, yes, I do believe you're correct. There should be other reports then, but we'll make sure to get them to you.
Oh, no, no, it's fine. It's just that I thought you might want us to have the most current report that you have. That's all.
Thank you.
Thank you very much. Mark, let's go on to the next item then.
Yes, sir. Item 6 is the ZSFG hiring and vacancy report. And I'd like to note that this is Ms. Hill's last meeting. She's moving over to DPW, and so let's give her a nice goodbye.
Well, so I'm not sure why you think DPW is better than DPH. We are very sorry to leave you after all these years of you really struggling and then being so successful. And I think, aren't we bigger than DPW?
Yes, you are. We are much bigger.
But her job that she's going to might be a little bit bigger than the one she has here.
Well,
Right.
we of course wish you well. So
Thank you, Commissioner Chow. It's been a pleasure working with you and Commissioner Green and all the other past commissioners as well. Of course, this has been an amazing 8 years, a roller coaster ride, but for the most part, we have done great things together, and I appreciate our partnership and our collaboration of reaching major milestones, and I'm optimistic as well as confident that this work will continue with the leadership that's currently in place. We have a couple of interim appointments while they permanently backfill my position. Kim Walden will be the interim director of staffing for Department of Public Health. We have Tara Stevens that's on the call now. That will be the interim ZSFG HR operations manager, and she will be reporting out after this last report out for me. She'll be reporting out every month thereafter until they permanently backfill the position. So I'd like to introduce Tara Stevens to the commissioners and the team here. Tara, thank you for joining. So with that said, we have the report in front of you, and there's not too many highlighted areas other than us again moving forward and trying to quickly fill these critical positions as quickly as we can. Still facing applicant challenges in some of the key areas like ED and critical care. Commissioner Green, one of your questions that you asked was about the more granular data on number 7 regarding the recruiters and the applicants and their reason for declining and the outreach that the recruiters provided. And we do have the granular data. I'm not sure how you want that presented to you. I mean, I have it in front of me. I can kind of quickly go through some numbers as well as share the data with you following the report, so you can see the full, all the data, all the outreach that the recruiters provided, and then you can follow up with questions you may have and subsequent reports that Tara will be happily to respond to. So just a high level, we, for the granular data from the candidates, we had candidates that declined offers, one, due to inflexibility of schedules. One, the response time it took from the time they've applied to, when they received offers. Lack of communication, never heard from anyone. Confused by multiple emails, confusion with the hiring process. Some are still interested, and awaiting some offers. We had several that, declined due to night shifts, and some was just lack of clarity on salary. So those are just some of the high level reasons of why we've had some of our candidates decline, which further explains, why we're looking to, partner with our nursing leadership as well as our HR leadership of ways to remove some of these, barriers, right? And to be more responsive to our candidates and increase our visibility, our transparency, and our customer service. But, again, we wouldn't have known this was, some of the reasons why some of our candidates declined if we didn't do this outreach effort. But it also allows us to now work on processes to reach out to our candidates, following a recruitment, as well as our new hires upon hire, and to understand, to get a survey of their onboarding experiences or their hiring experiences, so we can look at ways that where we can improve, so it's not so impactful to future applicants as they apply to our department. And so working on those, sharing those responses with the hiring managers, with our recruiters, with our leadership, will allow us to, again, look at ways we can improve on our end, on the HR side, going forward, as well as, Tara will be working with the hiring managers on ways we can be more transparent and a little more flexible on the hiring manager side. So I wanted to, share that information, but as well as we'll look to Tara to share the full report of the outreach for next month. So that's pretty much the highlight of what I have from the report out. So I'll stop there and see if you have any follow-up questions for me, or any additional questions you may want going forward for Tara to respond to.
Mark, do we have anybody on the line?
There's no one online, commissioners.
Okay, Commissioner Green?
Yeah, well, first of all, Karen, I want to wish you all the best in your new position. And I have to say, I remember the first day I came to the commission meeting in the gigantic room with a gigantic table and all these people I didn't know and all these abbreviations I didn't know what they were. And you were so personable and so approachable. We bonded over necklaces, remember?
Right, jury.
to learn it from that person. But you know, I really, really have enjoyed working with you, and I just think you've done such a terrific job in such a very difficult time. I mean, especially when we first started, and you know, we had the civil service processes and so forth. And I mean, you always maintain such a positive attitude and a can-do attitude, and you know, every barrier sent your way, you just pushed it out of the way. So they're very lucky to have you over at your new position, and so we'll really miss you. And if you find any new jewelers, let me know.
Thank you, Commissioner Green. I really appreciate it. Thank you.
I know we're gonna probably have this come up next time, but I wondered, maybe you know, was there anything that really jumped out at you in terms of this list of reasons that people declined that really filtered to the top? And then also, do you have any sense of the percentage of people that you did the outreach to that actually responded? So is this really a representative response? I was just curious. And then the last thing I'm curious about is what is the strategy for utilizing per diem? Because we certainly have so many people that just want to work per diem. And at our place, I think it was 60% they get benefited, and that's a whole cost situation for the hospital that they are reluctant to pursue. But we've lost so many good people because they aren't offering as many per diem slots. So I wonder if you could just hit those three things.
Yes, and apologies, because you did have a second question to the question about the granular data. And so about the per diem. So yes, you know, that's always been our solution to, you know, filling in the gaps until we can get higher benefited positions. But, you know, that's been a challenge with us, you know, coming out of bargaining this year. And so, you know, our goal, not just for this year bargaining, but our overall goal is always to hire benefited positions, right? And we always focus on trying to transition our per diems into benefited positions. But, you know, as we know, the flexibility of being a per diem is much more, you know, it's much more attractive than you know, being a benefited employee, taking a 2320. And so we are trying to kind of you know, trying to fill 2320s and not as many per diem. So that's our goal. That's the overall goal. And that's always been the goal. But we know we have challenges, and we know there's an operational need to fill in gaps. We have, you know, we have, you know, patients that we have to take care of, and we don't have the adequate staff, and we want to be able to get staff in as quickly as possible. So we always resort to per diems. But, you know, it creates a challenge for us as we, you know, try to respond to unions about, you know, the high number of vacancies. So while we know we have to, you know, fill, you know, our positions as quickly as we possibly can, but we also know we have the responsibility of patient care. And so, you know, we will utilize the per diems as a, you know, main resource until we can get our benefited positions filled. So we will start seeing a decline in the use of per diems, and as we try to, you know, fill and focus on filling our 2320s. So we, you know, the push will continue to have those per diems apply for our benefited positions, to apply for our training programs, commit to a more, you know, stabilized position and not just, you know, per diems. And so that's going to be our focus in HR. And you know, I'm sure, you know, Susan and Jillian, you know, can speak to that as well. So, you know, I don't think it's just a lack of benefits or us trying to reduce the per diem usage to avoid benefits. I think it's just the goal is to try to stabilize our workforce and hire 2320s, to hire the benefited nurses. You know, Susan, I'm not sure if you want to add to that, or Jillian want to add to that regarding the per diems, but you know, that's kind of the approach for HR.
Yeah, I just to underscore, you know, permanent is always preferred, but I'll defer to Jillian to see if she wants to comment about nursing and how we're making do in this, you know, in this environment where there are shortages of nurses everywhere in every healthcare organization, as you know, Commissioner Green.
Yeah, Commissioner Green, you hit on a hot point for us, which is that we have staff that are constantly leaving because they don't want to work full time, and they take per diem positions. And one of the things that Susan, myself, Jennifer Boffey, and HR we've been talking about is making and increasing the number of part-time positions in hopes that we will be able to retain some of the senior people that are telling us, no, I'm going to go. It's easier for me. It's better for my family if I work per diem. And so probably over the next 6 months, we're going to have a shift in terms of some of the numbers of part-time positions that we're offering. I think we all recognize that the face of the workforce has changed, working from home. With COVID, I think everyone has been, uprooted, and people are now doing things so differently. And so that is one of the strategies that we are planning to implement. And I am sure that our union partners will be happy about that, because that was an issue for them when we were in bargaining.
Well, thank you so much. You just hit on exactly that. I mean, I have a small sample of nurses I work with, but it's about 120 in our OB unit, and most of them love per diem. It's almost like when the gig economy came in, and the allure was that you could set your hours, and the nurses really want that. I mean, whether they're grandmothers or whether they're new moms, they really want that flexibility. And it seems that the institutions that offer it are going to be the ones that at least will be able to fill the positions and take care of the patients. It's almost like a marketing advantage in a way, but it's so popular, and I know it's very difficult. And then there's seniority issues where if you're senior but you go per diem, there's all things I don't understand, but I get to hear some of the grumbling that goes on. But it certainly sounds like you're right on it, and it's exactly a way to possibly find more staff in a low resource environment.
Thank you.
Thanks, Jillian, for that. And just to know, about the flexibility and scheduling, would be, a sure hit to have, the applicants, want to accept positions with us. So, that was one of the, major factors as well, the schedule flexibility. But, Commissioner Green, to, answer your question regarding the number that we reached out to, I mean, the responses don't represent, of course, the entire applicant pool, a small percentage. And so, while it is a small percentage of responses that we received, but it was enough for us to understand where some of the gaps are. And if we expanded that to the larger, they probably would fall in one of those, buckets about scheduling and the communication and, maybe, confusion in our processes. And it allows us to kind of step back and look at ways that we can improve. Specifically, in HR, our level of, of service as well, because I think, our goal is we move so quickly because we want to, quickly fill the positions, but we forget about the customer service piece, the humans that we are communicating and working and dealing with humans. So I see there's areas of improvement on our end as well, and we're committed to, to look at those areas of improvement to improve candidate experience, candidate and applicant experience as well. But hearing the flexibility within scheduling will also help at the same time. And then hoping in the next couple of months, over the next couple of months and in the future, that our responses to offers to Department of Public Health will increase. So that's, of course, the overall goal, and always been the overall goal.
Well, thank you.
Thank you, Karen. And I would hope that as you present more detail on the survey, and the survey is helpful, it sounds like, because a number of things should be resolvable. It would also be good to hear what steps are being taken to try to address the problems that you feel could be addressed, so that we understand that you're not only surveying for where the problems are, but trying to resolve them. And if there are areas that you might need additional help, then we need to hear those. So otherwise, dreadful that we're not going to be able, well, first of all, regretting that we can't say goodbye in person, because I also remember when you first came, you were sitting at the very far end of the table. And, and I think we were going through a lot. Well, we've gone through a lot of personnel issues, haven't we?
Yes.
Even before Commissioner Green came. And,
Right.
many challenges, and you've really come up to the plate, and you've hit many home runs for us. So thank you very much, and good luck in your next endeavor.
Thank you so much, Commissioner Chow. Appreciate it.
Okay, Mark, let's go on to the next item.
Of course. Item 7 is the medical staff report with Dr. Winston.
Hello, commissioners. Good afternoon. So the first item on the medical staff report today is the clinical service report that Dr. Barbara Haller did regarding the laboratory medicine service that was presented at MEC. And Dr. Haller gave, a very comprehensive and well-received review of, all the really impressive things that our lab has been doing, in addition to really managing very impressively with the additional stresses, of the pandemic. So we were all extremely appreciative. Dr. Chow, I think you had one question on the report. Really appreciate your sending this to us in advance. But there is a comment regarding the finances that says that the revenue is $387 million, but that the expenses are $27 million. And that sounded funny. So I reached out to Steve Peacock, who is the administrator of the lab, and Dr. Haller, and they clarified, those two items actually aren't connected in the way we might think they are. So that the revenue that they listed in the report is the billable amount that they that is billable to insurance for tests. Most of these payments are billed to Medicare and Medi-Cal, although some may be billed to private insurance. And the return for that billing is thought to be about 12 cents on the dollar. However, the clinical laboratory does not really have exact visibility into the amount of actual reimbursement. That money comes back to the city's general fund. It doesn't come back to the laboratory. So the expense that was listed, which is really the clinical laboratory's budget, it combines funding from the affiliation agreement with UCSF for the clinical laboratory services, their resources and supplies, and additional funding from the city for materials. So I think that's why it looked like those things didn't quite match up. So happy to see if there's any additional questions on the laboratory medicine report before we go on to the action items.
So in fact, the 387 is really the billable amount.
Yeah, and it's not what's returned.
Oh, no, I understand. I had a billable amount on my laboratory studies, and the facility got something like a tenth of that. So that's escalation and inflation of our costs. But I'm glad you clarified that, because otherwise it was going to be an outstanding result. But that sounds much more like the reality in terms of maybe 10 to 12% return. Yeah, okay. No, thank you. Commissioner Green, did you have any questions on the report? It was an excellent report, and they obviously do an awful lot of work. And I didn't realize they're moving to new quarters, or just part of it is moving to new quarters?
Yeah, our clinical laboratory isn't exactly moving into new quarters. Part of the laboratory is being redesigned and updated. So in the interim, parts of the processes are kind of pushed over into a different part of the lab while those renovations are in progress. They'll largely be staying in the same location.
Oh, okay. Thank you. Dr. Green, do you have any other questions?
Well, I think it was a comprehensive and amazing report, especially with the sudden escalation of tests that COVID required. I mean, out of the blue, they had to basically almost have a separate organ affixed to them. And it's remarkable they were able to keep up and do as well as they did, as we've heard over time during the pandemic. I guess the only thing I wondered about, and I think it links back to the hiring issues. I was worried about the comments here, not only that it's incredibly hard to hire laboratory scientists, but also when I saw the part that there was a $5 million less spent than budgeted, but that it was probably due to the departure of many staff members. So is there any comment about that? I mean, it's such a competitive market and, so worrisome. I just wonder if the people that are there currently are under a tremendous amount of stress because they're, stretched so thin, or where that stands. I actually looked at the employee, the report from the vacancy report, and I couldn't really link vacancies with spots within the clinical lab. I didn't, because the definitions in the staffing report are sort of general. So I wondered if that had been brought up.
So, so I don't think you'll be able to see it on the hiring report because these are going to be UCSF employees in the laboratory. So, so the lab is concerned about that. But I think one of the ways the lab has been extremely successful is through its teaching and training programs. So they are actually able to recruit a number of people from the various training programs in San Francisco, and they really promote from within. So a lot of the folks who have come in through the training programs over the years are now at the most senior levels in the lab. So, but they've been working very hard on that, and they're the supervisor level in the lab is really spectacular.
Great, thank you.
If there aren't any questions on the report, Dr. Winston, do you want to proceed?
Absolutely. So then in terms of our action items, the first one is the laboratory medicine rules and regulations that Dr. Haller updated in conjunction with the service report. And I believe you have those. The changes were relatively minor. There was a nice update to their, organizational chart, which was very helpful. And I think you have both a summary of changes and the red line version and track changes. So happy to see if there are any questions about that.
Commissioner Green, any questions?
No, I have none.
On the on that portion of it, okay. So proceed.
Okay, perfect. So then just a few other items. So we have two standardized procedures to look at today. So one is the CT guided spinal steroid injection, which is a standardized procedure in the radiology department. And I think you both had a couple of questions about this that I wanted to address. So Dr. Chow, I think your question was which staff would this be authorizing? And the standardized procedure is for either a nurse practitioner or a physician's assistant. But in this case, there's only one person in the department who is requesting that, and that is a very dedicated nurse practitioner who has been training in this practice. And you were wondering if there are other facilities where these spinal injections can be performed by non-MDs. So the Credentials Committee actually had that same question and did some outreach. And the nurse practitioner who's going to be applying for this standardized procedure also did outreach to at least two other institutions and the requirements for training are at least partly based on what she learned from talking to those folks about the type of proctoring that they require for their standardized procedures. And then, Dr. Green, I think you were appropriately wondering, who's going to be diagnosing the patient, determining if the patient qualifies for injection, determining the site, and if this isn't done by the NP, what's the chain of communication? So both Dr. Wilson and the neuroradiologist who oversees this in the department and the nurse practitioner who's going to be applying all confirmed this workflow. But so when a provider refers a patient, it's based on the clinical symptoms and imaging findings. If the patient does not have spine imaging already, they're referred by MRI of the spine. In most cases, the referring provider is going to be a spine specialist, which in our case is a neurosurgeon, an orthopedist, anesthesia, neurology, or the specific spine clinic. And they use all of the above information to recommend the neuroaxial procedure and submit a request. The NP then reviews all the imaging with the neuroradiologist prior to the procedure to ensure that the correct site is treated. And if there's a non-specialist referring provider that's requesting a neuroaxial procedure, the nurse practitioner and the neuroradiologist and or neurointerventional radiologist very carefully review that to determine appropriateness, make sure that the appropriate neuroimaging has been obtained, and they may not initially decide to go forward with the procedure until they have a discussion with the referring provider to make sure that it's appropriate. So it's actually a pretty comprehensive workflow before the procedure is performed.
Thank you.
So just wanted to check if there are any other questions about the CT-guided spinal steroid injection.
So I guess now that you've described that this is a procedure for the injection, and not then, as Commissioner Green was speaking of, who makes the decision for that, because that's in some other part of the protocol.
So I don't think there is a specific protocol for that. In general, when we have standardized procedures that, are analogous to privileges, they don't specifically outline the thought process and referral process for how the patient gets there. Those are more, standard practice, appropriate medical standard within the department. But certainly the radiology department takes that very seriously and does not want to be performing this or any other procedure, if it's not appropriate. But it's not part of the standardized procedure.
Okay, so I think what you were describing is that it would be ordered by appropriate people and also agreed to by the radiology department people, and then they would find one of their people who are then skilled to do it. And this is to describe the procedure in which it's done. Right?
That you are exactly correct.
Okay. Commissioner Green, any other questions then from that?
No, that makes a lot of sense.
Okay, great. And did you want to describe the last privilege procedure changes then?
Certainly. So I think these are less complicated because these are not new privileges or standardized procedures. So the influenza vaccination standardized procedure is going forward with no changes from prior. And then we have two updates to privileges. One from the Department of Medicine in pulmonary critical care. And the reason for that update is the way they were previously listed is that all of the critical care privileges were under the umbrella of pulmonary. But there actually are separate boards for pulmonary and critical care. And we do have a physician who used to be boarded in pulmonary. But since that physician now only attends in the intensive care unit and does not do pulmonary consultation, that physician needs critical care privileges under the division, but not the pulmonary privileges, only the critical care privileges. And as we go forward, it's reasonably likely that there are other folks who may fall into this category. So Dr. Graham, who is the division chief for pulmonary, has just divided out the privileges so that you can have separate, under the pulmonary division, you can have separate pulmonary privileges and critical care privileges. But the content of those privileges is essentially the same as they were before.
Okay.
And then the last change is just to the neurology privileges list. And Dr. Hemphill from neurology realized that we needed an update because one of the neurology boards was now offering critical care privileges. And so that needed to be updated as a potential qualification for the neurocritical care privileges.
Okay. Further questions, Commissioner Green?
No,
Or else, there's still nobody on the line, Mark?
No, sir, no on the lines, and and you all can vote on all of the items together.
Right. So a motion is in order to accept the items that are proposed for a revision.
move to approve.
And I would second that.
Thank you, and because there's two of you, then that creates an action. So thank you very much for approving that. Everything is passed, and we can move on to item. Thank you, Dr. Winston. We can move on to item 8, other business. Hearing none and seeing no one on the public comment line, we go to item 9, which is the public comment. There's nobody there, so we can move on to a consideration item 10 of a closed session.
Move to go into closed session.
And I would second that.
All right, thank you. Again, that's an action, so give me 30 seconds to switch us over. If anyone who's in the room now does not belong in closed session, please say goodbye and thank you for attending. Otherwise, we'll move over in a minute. Okay, we are back in open session. Commissioners, please consider a vote to disclose or not disclose discussions held in closed session.
Move not to disclose.
And I would second that.
All right, we'll take that as an action because there's two of you. And we are now at a consideration for adjournment.
Move to adjourn.
And, okay. And I would second that, thanking everybody for their attendance and involvement and their comments. So we will adjourn into our next meeting.